Good day. Today we will be talking about foodborne disease. This dissertation video will be quite similar to other videos that we made, but will have some specific attributes that make it special, since we will be looking at the same pathogens, but from a different point of view, where we will not only have infectious pathogens or infectious etiologies and look into them. We will be looking at a mechanism, which is ingestion, and this is disease that come with food. In other videos, we looked at intestinal infection from a clinical point of view, where we classified them into more of a non-feverish diarrheas and feverish diarrheas and typhoid fever. Now we will look at every single disease that can occur when we have ingestion of materials. Of course, we will go more into detail into the infectious part, but we will go also in other parts that can mimic this process. So, as an overview, we start by a definition that foodborne disease is a result of ingestion of contaminated food, including pathogenic organisms or their toxins or chemicals. The most common transmission include food, but other routes may exist for sporadic cases. These other routes could be with contamination by hands, small contamination of highly chemical substances. The most important part is outbreak investigation to identify the food and contaminants, because usually the patient has ate too much within the last few days to be actually able to pinpoint which was the main reason. That's why outbreak investigation can give us sure answers. Foodborne disease surveillance and outbreak investigations in the United States provide the major source of information. If we talk about epidemiological data, between 2009 and 2015, there were almost 6,000 reported outbreaks, resulting in almost 101,000 illnesses. Of them, we had almost 6,000 hospitalizations and 150 deaths. For the US, this is apparently small numbers, but if we compare these same numbers with other countries, the percentages will be higher. These figures underestimate the true magnitude because we have underdiagnosis. Estimation of the cases in the United States is around 3,000 deaths, which is more close to the reality of the situation. The economic burden can range from 51 billion to 77 billion. The Center of Disease Control of this center surveys foodborne disease and conducts active surveillance for 9 common enteric pathogens transmitted through food. And this gathering of statistical data helps them understand how to better investigate and better have prophylaxis. Incidence of infection with laboratory confirmed Shiga toxin producing E. coli, STEC, Yersinia, and Cryptosporidium increased in 2016. This has to do more with the introduction of new protocols that had clinicians investigate more and better sensibility of the laboratory data. The spectrum has expanded, since norovirus are now recognized as the most frequent cause of foodborne illnesses in the United States. New causes of foodborne disease have been identified, such as EAEC and novel strains that can produce Shiga toxin. New bacteria like Trypanosoma and Coronabacter, which cause Chagas disease, has also been recognized by the CDC as foodborne pathogens. Previously uncommon food vehicles have become important sources of contamination. For example, fresh produce in farmers market and flour are now recognized as significant sources of foodborne illnesses. And antimicrobial drug resistance in certain pathogens have increased. This follows a trend in the United States to go back into farmers' market without the culture that comes with such local production, since the population has been educated on how to deal with industrialized vegetables that have been cleaned by the producer and by the shipping company, while local production lack the surveillance needed and the laws regulating the types of food that is produced, sold, the types of manure that's given to these plants, the types of chemicals put into these plants, and the way that the people kind of manage and disinfect their own product at the end of the day. That's why we can see this trend, especially in the United States. The centralization of the food supply in the United States increased the risk of nationwide outbreaks while decreasing the risk of small sporadic cases. The global food trade with its complex network facilitates the spread of contaminated food worldwide and hampers source identification during outbreaks. This can be seen where we will have some cholera patients that have consumed seafood that came from other countries that still contained the bacteria from the contaminated water. And this scenario kind of reminds us with the complex trade network that happened during the Roman Empire before the plague. Now, if we go into the clinic of foodborne disease, it can occur as sporadic cases or outbreaks affecting a group of people after shared food exposure. Usually, sporadic cases is, as we said, someone bought something from a local farmer or a local producer, didn't clean it well, didn't do the prophylactic measures well, and got the disease. Or, if we are talking about outbreak, it's more about a big restaurant chain or a big producer and shipment company that had contaminated source of food distributed on a large scale. How do you suspect an outbreak? Is when acute illness, especially with gastrointestinal or neurological symptom, affect two or more individuals who had a common meal. Acute foodborne disease can be categorized into syndromes based on signs, symptoms, time of onset after consuming contaminated food. So, for example, if we have nausea and vomiting lasting less than 24 hours, the first two foodborne diseases to consider are typical food poisoning with the etiological consideration of Staphylococcus aureus and Bacillus cereus. These diseases are caused by preformed toxin and not by the bacteria itself. We have a really short incubation period of 1 to 8 hours. And if we're talking about the staphylococcal food poisoning, 87% of cases will have vomiting, 89% would have diarrhea, and 72% will have abdominal cramps. Fever is uncommon as it comes with 9% of the patients only, and it's usually caused by the excessive vomiting, the inflammation and irritation of the esophagus, and dehydration. They produce serologically distinct enterotoxins, with SEA being the most common. There is no point of actually checking for the toxin since the disease is self-limited and the treatment is easy by fluid management. And even if we have an outbreak, it gives no clinical purpose. The only clinical purpose that could give if the patient will be sick for more than 24 hours or more than 2 to 3 days, then it's no longer staphylococcal food poisoning because the toxin is not stable enough to give us disease for more than 24 hours. The same goes for Bacillus cereus, where we have 100% of cases having vomiting, and abdominal cramps, but only 33% of them will have diarrhea. The emetic toxin is heat resistant and it stimulates the vagus nerve. Other enterotoxicogenic coagulase positive staphylococcal species and coagulase negative staphylococci are rarely associated with outbreaks. Another cause of vomiting with less than 24 hours is norovirus illness. The symptoms are acute onset of vomiting and non-bloody diarrhea, nausea, and abdominal pain. Fever is present in around 40% of the patients because of viruses provoking heightened cytokine production. And it lasts less than 24 hours and the fever is low grade. Symptoms usually resolve in 2 to 3 days, but medical care is required for 12% of patients, especially that these patients will be either kids or old people. And if we have severe dehydration, these patients might need hospitalization for fluid correction, electrolyte correction, and so on. They are the most common foodborne pathogen and can be spread from person to person or through fomite contamination. And this data is from the USA. The median incubation period reported in foodborne outbreak is around 33 hours. Related virus in the Calciviridae family, such as sapoviruses, can cause similar illnesses, and they are also self-limited. If we talk about watery diarrhea without fever lasting for 1 to 2 days, as we said, we are now making a small preview of what we talked about in the previous videos. The etiological consideration for watery diarrhea with and without fever for 1 to 2 days, which should be Clostridium perfringens and Bacillus cereus, but here it's the bacteria, not the toxin that we are talking about. C. perfringens type A food poisoning will have almost the same symptoms, but with more accent on the diarrhea part of it. Toxins are produced in vivo, which results in a longer incubation period, which is 9 to 12 hours compared to the previous one of 6 to 8 hours. The enterotoxin produces vegetative cell which sporulates within the intestine. CPE binds to the apical membrane of the epithelial tight junctions, which leads to cytotoxicity and diarrhea. In Bacillus cereus, when we are having the bacteria itself, we will have long incubation period. And we will have 3 component enterotoxins. We will have hemolysin and non-hemolytic enterotoxin and single protein enterotoxin. They have all been described in the literature, and it may be produced in foods or within the host's intestinal tract by the ingested vegetative cells of Bacillus cereus. Symptoms typically resolve within 24 to 48 hours and may last several days. This, as we saw, all these patients don't have bloody diarrhea, they don't have high-grade fever, and they don't need etiological testing, since most of them will be self-limited, and when the disease stops, we can look at the whole clinical picture and determine which disease was it. In rare cases, the patients may experience bloody diarrhea and fatalities have been reported. So when the patient has bloody diarrhea, we will start our diagnostic panel and then we will have retrograde diagnosis. If we talk about C. perfringens type C, Clostridium perfringens, this rare foodborne infection is fatal in about 20% of patients, and it occurs in individuals with low protein intake. It is primarily observed in Papua New Guinea, and it might be underdiagnosed in other areas and taken for other salmonellosis or typhoid or other foodborne infections. If we talk about watery diarrhea and abdominal cramps lasting for more than 2 days, then we should consider the ETEC and Vibrio parahemolyticus as the major etiological consideration. We should check for ETEC if it can last for more than 6 days and it causes illnesses through the expression of enterotoxin in the body. So the abdominal cramping is often throughout the entire illness and it is for around like 6 days. The uncommon symptoms are fever and vomiting. If we talk about Vibrio parahemolyticus or non-cholera Vibrio, they cause diarrheal syndromes in the United States. Outbreaks of V. parahemolyticus are uncommon, but they can still be reported as it is one of the bacteria in the diagnostic panel. The virulence factors are secreted toxins, effector proteins delivered into the cells, and the duration of such diarrhea is around 6 days. Most patients have abdominal cramping, while almost half may have vomiting or fever. Some may have bloody diarrhea, but as a patient with diarrhea more than 3 to 4 days, we will already be having our diagnostic panel. So now we go to the cholera toxin strain, which is important to identify since it needs antibiotic therapy. And it is within the watery diarrhea with no fever for more than 2 days. We are now into the 7th pandemic of the cholera with local epidemics, especially by the strains O1 and O139. It manifests as profuse watery diarrhea accompanied by muscular cramps. It is important to know that whenever we have a patient that is vomiting and having diarrhea so profuse, we should directly do our cholera tests and start empiric treatment, especially if the patient doesn't have fever. Now to diarrheas with abdominal cramps, diarrhea, and fever. We should consider NTS, Shigella, Vibrio species, especially the parahemolyticus. Campylobacter, STEC, Yersinia could be considered, but they have longer incubation periods and have less common fever. Norovirus can be considered, but as we said, most probably norovirus fever is not caused by the virus itself, but can be directly by cytokines caused by the virus or by the vomiting factor. Inflammatory diarrhea caused by invasive or cytotoxin producing pathogens. It is with pathogens that invade the intestinal epithelium or damages it with secreted cytokines. The most common symptom of this is bloody diarrhea. These illnesses resolve within 2 to 7 days, and you should give the patient supportive treatment during this time. If we dive more into each one of them, NTS, which is nontyphoidal salmonella, is the most common bacterial cause of foodborne illnesses and outbreaks in the United States, although Campylobacter in the latest few years have become a little bit more common, or as common as. The incubation period is from 6 to 48 hours, and we talk about Campylobacter. As we said, it is most common bacterial cause of gastroenteritis, especially gastroenteritis, and not in general foodborne illnesses. And in the United States, lately, it might have become the leading cause. They have conflicting reports from different areas. The important thing to know, its incubation period is a bit longer, from 2 to 4 days. We have Listeria diarrhea. It is infrequent and it is reported among previously healthy individuals. It includes frequent watery diarrhea, fever, abdominal cramps, headache, and myalgia. The profuse water caused by Listeria can get it mixed with cholera, but the fever can easily exclude cholera. Yersiniosis is a febrile diarrhea and it's most common in young children. In older children and adults, the illness may manifest as just a diarrheal illness or pseudoappendicitis syndrome. We can have multiple abdominal cramping syndromes, and it is sometimes mistaken for typhoidal fever. We have systemic symptoms associated, and the median duration of the diarrhea is 2 weeks. But some symptoms may persist longer, especially that the intestine, even after the infection have gone, the intestine needs time to regenerate itself. And we can talk about ileocecal mimicking appendicitis, especially in Campylobacter and Salmonella infections. If we talk about bloody diarrhea with minimal fever, the most important groups are STEC and primarily the O157. These strains produce one or both types of Shiga toxins, and it damages vascular endothelial cells in target organs. They are more virulent, especially the toxin 2, and the other virulence factors are the adherence to intestinal epithelium, which are necessary for disease causation. The symptoms of hemorrhagic colitis are caused by STEC, and they include severe abdominal cramping and diarrhea, with initially watery but may become grossly bloody. And about 1/3 of patients experience low-grade fever that resolves before even seeking medical attention. And most of the patients fully recover within 7 days. It is important to know that if our patient has bloody diarrhea with no fever, we shouldn't give these patients antibiotics, because these antibiotics will increase the risk for hemolytic uremic syndrome, especially in children less than 5 years. 6% of these patients, especially 15% of children less than 5 years old, may develop hemolytic uremic syndrome. It is diagnosed about 1 week after the onset of diarrhea, when the diarrhea is already resolving. The fatality rate is 3% for children and 33% for people older than 60 years old. The death in patients without hemolytic uremic syndrome are rare and usually only is people with comorbidities. And the mechanism of action of hemolytic uremic syndrome is quite interesting. It involves the bacteria itself. It involves inflammatory markers. It involves the inflammatory cascade. And it can be quite an interesting topic. If we talk about non-O157 STEC, they have diverse virulence properties. The range is from uncomplicated watery diarrhea to hemorrhagic colitis and even hemolytic uremic syndrome. Multiple outbreaks in the United States have involved multiple groups and serotypes. If we talk about diarrhea lasting more than 14 days, we should always check for parasites, especially Giardiasis, Cyclospora, Isospora, Cryptosporidium, and usually they are in HIV patients or in patients with malnutrition. So if a patient comes with diarrhea of more than 2 weeks, we should check if this diarrhea is actual diarrhea and non-functional diarrhea, because we might have patients with functional diarrhea, which is patients who had diarrheal disease and now all the symptoms have went away and we just see regeneration of the intestine with loss of functional reabsorption of water. If the patient does not fit this criteria, we should have a parasitic panel, diagnostic parasitic panel done on this patient. The outbreaks of cyclosporiasis linked to various types of imported fresh produce have been recognized in the United States. Incubation period is 1 to 2 weeks. The symptoms are the same as all the others, but with low-grade fever. Untreated illness can last for weeks or months with a remitting relapsing course. And this disease is purely epidemiological, so we should check our epidemiological status in our area. We can have something called Brainerd diarrhea. It is a distinctive chronic water diarrhea. It was initially described in people who consumed raw milk with the incubation period of 15 days, and affected individuals developed acute water diarrhea with marked urgency. It can persist for over a year in 75% of patients, and several restaurant associated outbreaks and cruise ship associated outbreaks suggest water transmission of the unidentified agent. It's one of the diseases that we still don't know what caused it. It's brain diarrhea, and we also have this diarrheal dysfunction and tropical sprue, which will be in our next video. We can have syndrome of cranial nerve palsies and descending paralysis. It is acute onset of symmetrical cranial nerve palsies, and especially if it's descendant and coming from proximal muscles into distal muscles, we should always check for botulism. Botulism is a cause of cranial nerve involvement, and it comes with symmetrical descendant flaccid analysis. That's how we differentiated from strokes, from other autoimmune syndromes that have more of a rigid and spastic paralysis. And it comes from proximal into distal. We should always have a good differential diagnosis with Guillain-Barré syndrome, which is a progressing paralysis from distal to proximal. So it can lead to respiratory arrest, and botulism is characterized by pattern of paralysis. Usually botulism is within contaminated fish, contaminated homemade canned food, since it's an anaerobic bacteria that produces its own toxin, and the infection and the disease is caused by the toxin itself, not by the bacteria. Associated symptoms in botulism. Among patients, 98% have dysphagia and blurred vision, slurred speech, double vision, and change in the sound of the voice. We could have nausea in 42%, vomiting in 33%, and diarrhea in 16%. As we said, the causative agent and mechanism of botulism is bound by one of four immunologically distinct heat-liable protein neurotoxins. They are A, B, E, and rarely F. They are the botulinum toxin. They irreversibly block the acetylcholine release at the neuromuscular junction, and recovery typically takes weeks to months as nerve endings regenerate slowly. We have different forms. Foodborne botulism results from ingestion of preformed toxin. Infant botulism and adult intestinal colonization syndromes result from the ingestion of spores with production inside the body, but it's a lot more rare. Why is it important to clinically suspect? Because it plays a vital role in the accurate diagnosis of botulism, because it is not in the panel, and the diagnosis is most of the time purely clinical. Now, if we talk about systemic illnesses, systemic foodborne illnesses, we can start with listeriosis. It primarily affects pregnant women, fetuses, and people with compromised cellular immunity. It is a mild flu-like illness in pregnant women and can lead to miscarriage, and can lead to neonatal listeriosis, which can result in early onset sepsis and late onset meningitis in newborn, and the fatality rate is around 20 to 30%. Elderly and immunocompromised individuals can have meningitis caused by listeriosis and focal infections and sepsis. That's why it is in the diagnostic panel of any systemic illness in the old population. The incubation period is around 11 days. If we talk about Vibrio vulnificus, which is a non-cholera Vibrio, it occurs only in patients with impaired immunity and especially those with chronic liver disease. It is especially with raw oysters and can lead to septicemia. It is accompanied by bullous skin lesion and the mortality rate is around 15 to 30%, and it is also one of the US specific infections. Other Vibrio species like Vibrio cholera and Parahemolyticus that do not produce cholera toxin can cause septicemia. NTS can cause bacteremia and focal infections, especially in individuals with extremes of age and specific conditions like hematological conditions. Campylobacter species, especially Campylobacter fetus, can cause systemic illnesses in immunocompromised patients. If we get to toxoplasmosis, it is caused by the ingestion of food contaminated with Toxoplasma gondii and can lead to different manifestations depending on the host. In healthy individuals, we have asymptomatic or mild symptoms that are nonspecific, while immunocompromised individuals may develop severe nervous system infections, which is having special ring enhanced lesions within the brain. And if we have pregnant person with toxoplasmosis, we can have congenital toxoplasmosis, which can have a really big variety of birth and prenatal defects. Trichinellosis or roundworm infection is from consuming raw or undercooked pork or wild game meats like deers and moose and stuff like this. This meat will be contaminated with larvae, and the gastrointestinal symptoms are fever, myalgia, edema, headache, and eosinophilia. Eosinophilia is the factor that will kind of hint that we should check for parasites. It can range from several weeks to months, and as we said, any kind of abdominal infection that lasts more than few weeks, we should check for parasites. So other infectious agents with primary symptoms outside the GI tract and neurological symptoms, we have Group A beta hemolytic streptococcus, typhoid fever, brucellosis, anthrax, tuberculosis, Q fever, Hep A, various trematodes infection, and anisakiasis and cysticercosis. To be honest, I don't know what is anisakiasis. Each agent has a specific food vehicle, example associated with transmission. And now to foodborne syndromes caused by non-bacterial toxins. Our first and most common is histamine fish poisoning, or called scombroid poisoning because it was first described in fish from the Scumbria family. They resemble a histamine reaction, and the onset is within 1 hour of eating the contaminated seafood. The common symptoms include flushing, rash, diarrhea, headache, perioral paresthesia, which is tingling or numbing around the mouth. We can have palpitations because of the repeated vasodilation in multiple areas. We can have sweating, itching, abdominal cramps, nausea, vomiting, and we can have really severe hives and bronchospasm. The mechanism is the histamine accumulation in fish flesh. These type of fish and multiple other types of fish have really high concentration of histidine in their fat tissue. The decarboxylation of histidine to histamine by marine bacteria happens usually when the fish sits at room temperature or at non-frozen temperatures for some time. And then we will have heat-stable histamine that will remain inside the fish. This is especially due to inadequate refrigeration, and we will have high doses of histamine. The scombroid fish poisonings have a very high attack rate, which means that if we give the same dose of histamine contaminated fish to 100 people, the majority of them will develop this disease. It is contrasted with seafood allergies, and usually it is hard to distinguish unless we know which type of fish the person ate. And seafood allergies are quite rare, while scombroid reaction is a lot more, since scombroid reaction doesn't need genetic predisposition. The symptoms usually resolve within 24 hours, and it's a self-limiting condition unless we have bronchospasm. Then we will need antihistaminic, corticosteroids, and the whole protocol of bronchospasm. If the patient comes with abdominal cramps, vomiting, diarrhea, followed by hepatorenal failure, we should directly look for hepatotoxicity and renal toxicity. Renal toxicity, hepatotoxicity, plus abdominal and food poisoning symptoms should kind of give us signs and hints into mushroom poisoning, especially cyclopeptides. These cyclopeptides are amatoxin and phallotoxins. They are usually in the mushrooms Amanita phalloides and Amanita virosa. These mushrooms have different names in different regions. That's why we put the Latin name in our video. The biphasic illness has the acute phase, which is a typical diarrheal syndrome that lasts from 12 to 24 hours, and a symptomatic phase, which is almost for a day, and the delayed phase. The delayed phase is a second phase where we will have the toxicity. It develops 2 to 4 days with the accumulation, the absorption of the intestine, the accumulation of these toxins inside the respective organs, which is the filtration organ and the detoxification organ, the liver and the kidneys. And the mortality rate in adults is about 10 to 30% depending on the dose, but usually it's more in kids who went into the forest without getting good preparing and start eating stuff they shouldn't eat. Although it is more common in berries for kids, and in mushroom we still have a big contingent of adults who just took the wrong mushrooms. We can have other mushroom poisoning like gyrometrin containing, which may lead to hemolysis, seizures, and coma. We can have the Amanita smithiana mushroom, which can have a more delayed renal failure, which is after almost 6 days. We can have the Cortinarius species that have the orellanine, and the renal injury develops around 2 days to 3 weeks after the ingestion. Once again, I put the Latin names because these mushrooms will have different names and kind of different identifying features in different areas and different countries. If we look at post-infectious syndromes, which are syndromes caused by foodborne illnesses but happen after or within the latest phases of the infection. One of them is reactive arthritis. It is aseptic inflammation of polyarthritis, urethritis, and conjunctivitis. It is associated with infection caused by Salmonella, Yersinia, Campylobacter, or Shigella. It depends on case definitions, and the attack rate might range from 1.2 till 29% in salmonellosis, for example. There is a big association with the HLA-B27 in the patient, and this patient will have other comorbid joint disease. If we talk about Guillain-Barré syndrome, it appears that almost 20 to 40% of Guillain-Barré syndrome cases attributed it to recent Campylobacter jejuni infection. This was not the case earlier. And from here, we have one of the most common cause in the post-Soviet countries, where every disease is either an infectious disease or a disease that we don't know the infectious cause of. And the Guillain-Barré syndrome is one of the main examples for this to confirm this quote. This might be an exaggeration, but just an interesting point of view. It manifests by ascending paralysis. It is contrasted to the descending paralysis of the botulism, and the sensory findings and abdominal nerve conduction velocity will be decreased. Why it is important to know? Because Guillain-Barré syndrome should not be treated with corticosteroids. It should be treated with plasmapheresis and immunoglobulins. That's why good clinical diagnosis and good epidemiological study and good history taking of the patient might save our patient long-term disease and disability. We can have post-infection IBS and functional gastrointestinal disorders. This is especially with enteric pathogens as Campylobacter and STEC, Salmonella, Shigella, Giardia, and norovirus. These symptoms may include bloating, abdominal pain, altered bowel habits, and discomfort, and the development of functional gastrointestinal disorders is preceded by diarrheal illnesses. If we get into the epidemiology, it is important to know the epidemiological status in our area and of our patient. Then this can give clues into which disease caused our illness. For example, if we look at the food consumed, Staphylococcus food poisoning is usually in ham, poultry, beef, potato, egg salads, pasta dishes, and sandwiches. The contamination source is usually food handlers with purulent skin lesions or contaminated dairy products. And it doesn't need to be a really big disease. A small pustula or a small formation on the finger of a person or on the hand of a person is more than enough to contaminate a really big batch. If we have the emetic Bacillus cereus food, it is usually starchy food since Bacillus cereus loves starch, and especially rice. So if you have the exam, you will have the classical question of someone ate leftover rice, fried rice in the fridge and got diarrhea within 6 to 8 hours after eating them, or within 4 hours. Usually it is Bacillus cereus. And the contamination source is heat-resistant spores that germinate in worm food and produces toxins. If we talk about Clostridium perfringens, usually it's beef and poultry that is improperly cooked, and the source of contamination is spores that are already in the meat and multiply when improperly stored or cooked. If we talk about diarrheal syndrome of Bacillus cereus, we can have the exact same contamination source, but usually it is in protein meat, since the bacteria within protein will be, the bacteria, the Bacillus cereus, when it is contained in food with protein, it will love to divide and multiply. But if it's within starches, it will love to become bigger and produce more toxins. If we talk about E. coli O157, the foods are uncooked ground beef, which is usually burgers, leafy greens, which can be also found in burgers. It can be apple cider, alfalfa sprouts, venison, salami, cooked dough, flour, but mostly it is burgers. It can be fecal contamination from cattle, environmental contamination, and contaminated water. If we talk about non-typhoidal salmonella outbreaks, the implicated foods are contaminated poultry, especially beef, fish, non-washed eggs, dairy products, juice, peanut butter, chocolate, cereal, frozen processed food. But since we have a really high infectious dose, just cooking our food well should be more than enough to save us from this disease. Contamination source is carried in intestine of animals and environmental contamination. We have raw milk associated illnesses, and this is raw milk and cheese. Usually it can be salmonella or brucellosis. The contamination source is non-pasteurized dairy products. Talk about Shigella outbreaks. The implicated food are cool, moist food, which are consumed raw. They are required handling after cooking, for example, lettuce-based salads that are mixed after preparation and kept cold. We can have potato and egg salad, that's usually salads, and dips that just stay on the table for a long time. The source of contamination is human carriers and ill workers. Talking about Campylobacter infection, the most common is poultry, especially undercooked chicken and unpasteurized dairy products. The cross-contamination is from poultry and it is found inside chicken intestines. If we talk about listeriosis outbreaks, it is usually because of raw sprouts, raw produce, deli meats, and it is usually environmental contamination. If we talk about non-foodborne transmission, apart from consumption of water, we can have contact with infected animals or person. Some waterborne transmission, it's in pathogens like Giardia, Cryptosporidium, which is drinking water from non-good supplies or from contamination of municipal water supplies. We can have recreational water transmission, especially in pools, in areas where we have a lot of kids swimming with no good sanitation. Person-to-person transmission is usually in viruses, and these viruses can contaminate food and water sources and cause large outbreaks, but also can be from person to person. If we are talking about population-wise, certain individuals have a higher risk and experience more severe illnesses due to factors related to inadequate immune response. The age-related factors are younger than 5, older than 65. Immune deficiencies, usually it's HIV, it can be leukemia, immunosuppressive medication, and malnutrition. Some other factors are diabetes, excessive iron stores, which is in cirrhosis and hemochromatosis, and pregnancy. If we look at seasonal patterns, some foodborne illnesses have seasonal variation. For example, summer month, it is Staphylococcus aureus, Salmonella, Shigella, Campylobacter, Vibrio species, E. coli, Giardia, and Cryptosporidium, since they need warm environments to survive. If we talk about warmer month, we can have shellfish association during warmer month because we have water temperatures increasing in oyster beds. If we have winter infection, it is usually viral infections with children that have really small areas to sit in during the winter, and it can be yersiniosis in black children. And especially it is when we will have pork chitterlings that are served in winter holidays. If we talk about geographic locations, we can have really big regional variations, and this is important for travelers' diarrhea. For example, O157 strain of E. coli. It is more common in northern states that are bordering Canada in the United States, for example, while Vibrio parahemolyticus is more reported in the uh, southern states. These, you are now taking the example of USA. This, each one of us will have to go through his own epidemiological data of his own country or region. If we talk about type E botulism, it is more common in Alaska due to the consumption of fermented marine animals among Alaskan natives. So another important point about infectious disease, that the person should know really well the local culture and the local habits. So epidemiological assessment, when we have an investigation process, is when a foodborne outbreak is suspected, we should contact the public health authorities. Common characteristics should be identified, like shared meals or shared sources or living area. Lab testing should be more broad, and we should try to isolate from foods, establishments, and patients. I'm sorry. Source identification is whenever a source identification, a food source is identified, the outbreak should be controlled, and we should focus on tracing of next patients. We should trace back to origins and assess the food ingredient sources, which may lead to investigations, or originating farms or plants or supermarket. If we talk about diagnosis of diarrheal illness, most of them do not require diagnosis. Stool testing should be considered in patients with specific clinical presentations, for example, fever, blood diarrhea, sepsis, illness in high-risk individuals. We should have blood cultures, for example, where we obtain blood, especially in infants with sepsis or suspected enteric fever, patients with systemic manifestations of the infection, with immunocompromised or high-risk population, and with possible exposure to a suspected enteric fever. If we talk about culture-independent diagnostic testing, this is to identify the subject for public health reporting goals. Some pathogens require going into reference laboratories to be able to diagnose them. This is especially if we have some kind of clinical suspicion of a specific pathogen, but we don't have this pathogen in our routine diagnostic panel. The reference laboratories can identify non-O157 STEC isolates, some other diarrhea-producing E. coli, and norovirus, for example. Some commercial diagnostic assays have appeared with PCR assays that can simultaneously detect and distinguish multiple pathogens. They provide quick result and may increase the identification of multiple pathogens. The advantages are speed and detection of multiple pathogens at a lower cost, but they cannot provide certain essential information, for example, like resistant patterns and susceptibility and pathogen subtyping. If we talk about foodborne outbreaks, the diagnosis should start always with stool or vomit collection. The samples should be also from leftover food or suspected source. They should be tested in food laboratories, not in clinical labs. We can have PulseNet subtyping network, which is a field gel electrophoresis and whole genome sequences, which can help us identify and investigate which exact strain or type or subtype of etiological agent is causing this disease. So if we talk about specific pathogens and their diagnosis, Staphylococcus aureus is usually clinically diagnosed. The outbreak can be confirmed, but usually it's only in really big outbreaks. Bacterial cirrhosis, also clinically diagnosed and isolated in feces or food only in big outbreaks. Clostridium perfringens is a part of normal microbiota, and toxin assessment is needed, not bacterial assessment. And outbreaks should be by isolating high number of Clostridium in food or fecal samples, but mostly is enterotoxin in multiple patients. Salmonella species, it's usually bacteriological diagnosis. Serotyping and susceptibility testing should be done to be able to give antibiotics to high-risk population. In Campylobacter infection, the bacteria is detected in the stool. It can be with antimicrobial susceptibility later for specific patients, but usually it is not needed. If we talk about Shigella, it is by isolating the organism from stool samples. Talking about E. coli, it is a bit more complicated, where we should use culture method or molecular assays. A lot of people love to use molecular assays, but serotyping and virulence detection and antimicrobial susceptibility are really important. So culture method is more useful. If we talk about Vibrio species, they can be isolated from stool, wound, or environmental samples, and antimicrobial susceptibility should be tested. If we talk about Yersinia, this yersiniosis should be confirmed diagnostically, and we should check for resistance because our patients are almost always at high risk. Norovirus is detected by RT-PCR, and it is important, especially in kids outbreak. It is a part of the panel of almost all countries. Rotavirus is the same, and it is by immunoassays or PCR, and genotyping can be performed in outbreaks, but usually is just a part of the panel. If we talk about Cryptosporidium, it is used for HIV patients, and PCR is now the most important factor. Giardia is suspected clinically and detected by direct microscopic or PCR. Antigen detection methods can be available, but they have limited clinical relevance, especially in patients who spend a lot of time in the wilderness. If we talk about Entamoeba histolytica, it can be detected using microscopy, but serological detection is the most common way to diagnose right now. Now we get to treatment. Treatment in most of our foodborne disease is supportive measures. Etiological treatment or etiotropic treatment is not needed most of the time. The mainstay for most therapy for most foodborne illnesses is supportive measures. The focus is to replace fluid losses, the use of over-the-counter oral rehydration solutions for mild cases, or IV hydration for severe dehydration. And some countries have second-line treatment not consisting of IVs, but consisting of nasogastric tubes. So if we talk that early IV, for example, hydration in oligoanuric hemolytic uremic syndrome will reduce the risk. If we talk our patients with hemolytic uremic syndrome, for example, we should add other than just fluid solution administration. We should have blood administration also. Talking about oral rehydration therapy and fluid management will be in our next video. If we talk about antiemetic and antimotility agents, they offer symptomatic relief, but they are contraindicated with patients with high fever, bloody diarrhea, or fecal leukocytes, which indicate inflammatory diarrhea, or with patients that have toxin contamination. So usually if our patient is having his symptoms for less than 24 to 48 hours, antidiarrheal and antimotility agents should not be given. And they are strongly unrecommended for children. For example, if we have botulism management, for example, we need high intensity in ICU units, supportive care, and especially with mechanical ventilation. If we talk about antimicrobial therapy, most bacterial diarrheal illnesses for healthy individuals do not require. Empirical antimicrobial therapy should be in specific cases. In infants, especially if less than 1 year old. In immunocompetent patients with fever, abdominal pain, bloody diarrhea, and bacillary dysentery, presumptively due to Shigella. If the patient is with recent international travel and fever and signs of sepsis, because this patient is now getting exposed to a new bacteria that he is not used to, so his immunity might need the antibiotic boost. If we talk about immunocompromised patient, first one was immunocompetent patients with signs of shigellosis, and immunocompromised patient with any type of severe illnesses and bloody diarrhea. And if the patient have suspected enteric fever, then we should start this patient on antibiotics. The choice of antimicrobial agents is based on factors such as local susceptibility patterns and travel history. The modification and discontinuation of therapy should happen when we will have culture results. The caution should be done because antibiotic treatment of non-typhoidal salmonella may increase the risk of long-term carriage. If we have STEC O157, the infection will have increased risk of hemolytic uremic syndrome, and antibiotics are not effective in food poisoning. These antimicrobial agents are life-saving in invasive salmonellosis, invasive listeriosis, and in Vibrio septicemia and typhoid fever. The most common antibiotics for the upper disease that we talked about is fluoroquinolones, macrolides, and lately with resistant emerging, we have third generation cephalosporins. For Vibrio cholera O1, the first line agent is azithromycin, doxycycline, or tetracycline. If we talk about parasitic infections, antimicrobial agents might be used for treatment, and specific information on treating specific parasites can be found on the CDC website, since there is too many parasites and they have little clinical importance for each one of us because they are too locally specific. We should consider antimicrobial pattern when selecting therapy, and the consequences of therapy can be, for example, if we give therapy to a resistant strain, we will have a complicated therapy because we have just attacked our microflora, the field is empty, the resistant bacteria is having fun, and it will complicate all of our treatment. We have a greater risk of invasive infection and hospitalization for the reason that we just talked about. That's why the prudent use of antimicrobials in human are recommended, and the same goes for animal gastroenteritis. So One Health approach is advocated because healthy cows and healthy chicken and healthy sheep will give us healthy human. That's why we should be treating and having prophylaxis to our patients, and as doctors and as people in power, we should, or as consultants to people with power, we should also check that our food sources are also being treated correctly. If we talk about botulism, we should implement close observation and supportive care. The health department emergency should be contacted. This is especially for the USA. The CDC clinical consultation and possible release of botulinum antitoxin is available in the USA. Supportive care and mechanical ventilation are crucial. If we talk about other poisoning, for example, paralytic shellfish poisoning and ciguatera may require ventilatory support. IV mannitol may provide benefit in ciguatera. Amitriptyline and tocainide may improve the dysesthesia, and enemas may be used to remove unabsorbed toxins. And for example, in scombroid poisoning, we can use H1 and H2 antihistamines, and some cases may use intubation and epinephrine. How to prevent foodborne disease? So, we should monitor the food production systems. That's because we have interconnected and centralized global food supply. Monitoring of food production in this global food supply is essential. We should pre-process the food for consumer convenience, and it should be done with care to minimize the contamination. The proper preparation, selection, and storage of food. The careful handling of animals, raw products, and processed foods is necessary from the farm to the table, according to the One Health principle. It can prevent many illnesses. Bacterial pathogens grow usually between 40 to 140 Fahrenheit, and usually it's around 20 to 30 degrees Celsius. It can grow even at 15 or 10 degrees Celsius if left for a long time. So, hot food should be kept above 140 Fahrenheit in the United States books. And if we look into literature that is more Eastern, we can check that hot food should be kept around 60 to 70 degrees Celsius. Thorough cooking of food before consumption eliminates the risk of many illnesses, except for staphylococcal food poisoning, as staphylococcal enterotoxin are heat stable. Raw chicken, beef, pork, shellfish, and eggs require special care in handling and cooking to prevent such foodborne disease. Contamination can occur in kitchen if cooked or ready-to-eat food come in contact with raw animal products. So even if our product is monitored, if the animal is well, if everything we are doing is correctly, if we did everything correctly, but at the last stage before serving the food, we contaminated our hands with raw food, then handled the correctly cooked food, this food can be contaminated and can cause illnesses. Poor personal hygiene by food handlers can contribute to outbreaks of norovirus, staphylococcus, shigella, and hepatitis A. And this is exactly what we just talked about. If we talk about high-risk environments such as travel or high-risk hospitals and establishments, these areas must prioritize food safety. For example, nurses, nursing homes, hospitals must use everything pasteurized eggs instead of shell eggs. They should use low microbial diets for vulnerable patients, and certain high-risk foods such as raw milk, seafoods, and undercooked meat should not be given. If we want to prevent chemical intoxication, it is usually caused by handling errors, and it differs from bacterial outbreaks. For example, this includes metal poisoning from storing acidic beverages in defective metallic containers, and for example, ciguatera and shellfish poisoning from unsafe seafood sources. The refrigeration of raw fish can prevent scombroid fish poisoning, for example. One of the key aspects is educating patients and caregivers. Clinicians play a role in this education, and we should give this to patients who are at increased risk of foodborne disease. For example, pregnant women, mothers of newborns, older adults, and immunocompromised individuals. These patients can make informed choices to avoid high-risk food, and this way everyone can benefit from following a good food handling practices. The role of clinicians and microbiologists is to detect the outbreak detection, detect the outbreak, and speed this outbreak detection. Rapid investigation of outbreak helps identify sources and trigger actions such as recalls, policy management, patient tracing, and source tracing. So, appropriate diagnostic tests and reporting them to the authorities are crucial to prevent and detect outbreaks. Timely recognition and reporting of initial cases can prevent subsequent cases in outbreaks. If we talk about intrafamiliar and institutional transmission, diagnosing and reporting illness with the potential of such spread can prevent secondary transmission. Public health authorities may exclude individuals from working or attending school or places where they are at higher risk to infect more people. Clinicians should counsel such patients with diarrhea on practicing hand hygiene, avoiding activities like swimming, water-related activities, and sexual contact while symptomatic. And this wraps up our video about foodborne disease. Thank you for staying with us until the end, and hope to see you in our next one. Hope this was beneficial to everyone involved, and hope that this covered enough information that was needed to be able to actually save our patients and not only prepare for our exams. Have a good day.